بسم الله الرحمن الرحيم. هنشرح النهارده السؤال ال17 من كتاب Interventional Cardiology and Interventional Cardiology Board Review. Question number 17. What is a Kugel's artery? Anomalous origin of the LED from the pulmonary artery, coronary arteriovenous fistula, conus artery branch, right to right collateral from proximal to distal RCA through the AV nodal branch. Kugel in 1927 described an artery which connected the proximal CX or RCA to the distal RCA or CX. He named it Arteria anastomotica auricularis magna due to its large size in comparison with other atrial branches. Only later the term Kugel's artery was applied to this artery involving the AV nodal supply and may anastomose with the AV nodal branch. RCA angiogram showing Kugel's artery in different views. In this figure, Kugel's artery originates proximal to the stump of an RCA total occlusion, anastomoses with the AV nodal branch, which arises from the posterolateral branch just after the crux. Also, there is Kugel interatrial ring, retroaortic ring, which is one of the three main rings connecting the right to the left coronary arteries at the level of the base of aorta. ودي الإجابة الرسمية اللي في الكتاب. The true answer is D. After branching from the CX or the RCA, it traverses the AV groove posterior to the aortic root. Then it travels within the basal inferior border of the interatrial septum. At the site of the membranous septum, it crosses the septum to give supply to the AV node. At this site, it may anastomose with the distal end of the AV nodal branch with a characteristic flag-like rectangular anastomosis, which may appear only if there is RCA CTO. عشان كده نقدر نقول in both REO and LEO views are important to differentiate this course and anastomosis with AV nodal artery to differentiate it from other atrial anastomosis. هل الكلام ده له clinical application؟ This is a real-life case. A 78-year-old female patient presented with inferior and posterior and RV infarction associated with a second-degree heart block. Coronary angio showed a small thrombus at the origin of the first septal, which is compromised or small in size, yet the second septal artery is large. Several right and left aortic sinus injections was done and showed no origin of the RCA. So internal pacemaker was connected and overnight tyrofibin was given for a next day a second angiogram. Next day the block was resolved. The coronary angio showed a patent proximal RCA, yet with a high thrombus burden in the mid and distal RCA, with failure of opening the distal RCA because of this high thrombus burden. عشان نعمل interpretation للحالة اللي عرضناها، عاوزين ناخد فكرة الأول عن ال AV node. ال AV node عامل زي محطة الكهرباء، بتعدي ما بين الاترم للفنتركل وقبل ما توزع الكهرباء للرايت والليفت سايد. First line of protection للAV node هو الممبرانous septum which surrounds the node. ممبرين السبتم بيعمل absorption لاي contraction من ال adjacent muscular septum، وفي نفس الوقت هيعمل absorption لاي traction force من الميترال valve أو التراكاسبيد valve اللي هم يعتبروا part of the fibrous skeleton of the heart. Second line of protection is the presence of anastomosis of four arterial supply surrounding the AV node. فبالتالي ال AV node هيبقى resistant to any block due to any ischemic insult. AV nodal artery is the main source of blood supply to the node. It arises mostly from the RCA just after the bifurcation with a straight course to the AV node. In 2% of cases, there is a dual AV node from both the CX and the RCA. First septal artery arises from the LED. It reaches the septum, right side of the septum, to supply the AV node from the superior part of the septum. Also, the Kugel artery and the right septal artery, both arising early in the from the proximal part of the RCA, have a role in supply of AV node, 40 and 70% respectively. The right septal artery is also known as right descending septal artery or descending septal artery. عشان الكلام يبقى له clinical application، أول حاجة هنتكلم فيها clinical interpretation. بسبب وجود الكوجلز artery and right septal artery، the incidence of heart block with acute total occlusion near the ostium is about 18 to 24%. في حين لما يكون في acute occlusion distally before the bifurcation، the incidence of heart block is only 13 to 15%. When there is acute proximal LED occlusion before giving a big first septal artery, usually the AV node is resistant to any ischemic insult because of the presence of other three arterial supply. When there is acute proximal LED occlusion before giving a small sized first septal artery, at this point there is usually a large right superior septal artery supplying the same territory, upper ventricular septum, by some authors called septal dominance, and the AV node will also be resistant to any ischemic insult. The other main role of the descending septal artery is supply collaterals to the left septal artery when there is proximal C2O LED occlusion. Either this septal artery arising from a separate ostium or proximal or common ostium with the RCA. In our case, we had a heart block from the start because of presence of total occlusion of the three arterial supply and compromisation of the fourth. After overnight treatment, the heart block was resolved, most probably due to restoration of flow of the first arterial supply from the proximal RCA, Kugel's artery, and right descending septal artery. نقطة مهمة جديرة بالملاحظة، the block was all the time narrow complex, most probably due to the presence of a large second septal artery which supplied the bundles and supplied also the distal AV node. So the ischemic insult was only supra-His. The other point to be considered is any technical issue during procedures. This is a case presentation in which the operator used a Kugel artery as a retrograde approach to open a CTO in the mid RCA. On the contrary, in this case, we can see Kugel's artery giving supply to the AV node and to the branch to the AV node, and which arises from the branch to SA node. The branch to SA node arises from the stump of a CTO occlusion. So any attempt to open this artery antegrade approach carries the risk of sinus arrest and also AV block. At least you will need a temporary pacemaker to be connected. Aortic root surgical procedures زي البنتال procedure carries the risk of cutting the origins of these small arteries, Cougles artery and right superior descending artery. في حين in the lower interatrial septal procedures زي mitral valve operations والradio frequency ablation carries the risk of damaging the anastomotic site branches from the different arterial supply to the AV node. لو حبينا نلخص الكلام atrial branches زي branch to AV node أو الكوجل أو الرايت descending artery have a crucial role in CTO cases either to give supply from proximal to distal or from the right to the left arteries. Good interpretation and analysis of the cases should be done even after semi-selective injections in the RCA trying to visualize any atrial connections. الحاجة التانية المهمة الارترز دي have a main role in preventing block to the AV node. So good analysis should be done with clinical interpretation. وبكده نكون خلصنا الفيديو. منتظر منكم الفيدباك وتحياتي للجميع.